Our speaker today is Maureen Statland. Maureen has worked with older adults and their families in suburban Chicago for over 40 years. She holds a master's degree in gerontology from Roosevelt University and a bachelor's degree in psychology from the University of Illinois at Urbana-Champaign. She is a former hospice volunteer with Journey Care, which is in our local area here, and currently serves as a volunteer co-chair of Compassion and Choices. Please help us give a very warm welcome to Maureen Statland.
Good morning, everyone. Hello to everyone in the room and everyone on the Zoom today. I'm excited to be here today and happy to tell you, you have an interesting time to be doing this, because if you saw the program description, it was called something about Illinois' pending legislation. When I applied to do this back in August, this was legislation that had been passed by the Illinois House of Representatives, and we were waiting to see if the Illinois Senate would take it up in the fall veto session. And they did at the very last minute, on the very last day of the veto session, somewhere between 2 and 3 in the morning. I was offline by that point, and Governor Pritzker signed the law on December 12th of 2025. So the program is a little bit different because I get to tell you, as it's now titled, the facts about medical aid in dying in Illinois. It will take effect, by the way, September 12th. There was a 9-month implementation period to get all of the I's dotted, the T's crossed, the systems in place to collect data on who's using this, why they're using it, how they're using it, and also to allow us at Compassion and Choices, ACLU, other organizations to do the community education so that folks like you know this is another option. Let's see. Oh, there we go. So first, a little bit about Compassion and Choices. We are the nation's oldest, largest, and most active nonprofit organization committed to improving care and expanding choice at the end of life. For more than 40 years, Compassion and Choices has provided support and resources for individuals and communities while working to advocate for patient-directed policies, practice, and care at the end of life. I do have some resources with me today, but we're at a very interesting time. As I told you, the governor signed our bill in Illinois just in December, and we'd all been holding our breath because we knew that the law had been passed by the legislature in New York, and we were waiting for Governor Hochul to sign that bill, which she did just last February, just last month. So some of our materials are still in process. I would normally have all sorts of handouts and materials with me. I have a few of the older ones that I'm happy to distribute at the end if anyone's interested. The only real difference will be those maps, because now Illinois and New York have legal medical aid in dying. Before I continue with the presentation, just one caveat. I like to try to keep my bio really brief, but to let you know, one of the things you didn't hear in there, I'm not a doctor, I'm not a nurse, I'm not a medical professional, I can't answer specific questions. I can just tell you what I know about the law that's been passed that me and hundreds of volunteers across the state worked for over 5.5 years. It'll be almost 4 years this summer. And one of my partner volunteers is here in the audience with us. We were literally advocating for this bill in the Capitol during a tornado in May. We happened to be down there for an advocacy day when not only the tornado sirens went off, but there was actually a tornado in Springfield. But it gave us a wonderful chance to get to know the basement of the Capitol system, and we were all down there together. That said, I know this is a tricky topic sometimes to talk about dying in America. It's something that we are, as a society, no matter how old or young we may be, are often loath to do. But I think it's very important that we have those conversations at every age. I understand I'm talking to the senior audience today, but most of us want that top picture that you see there. Most people, when surveyed, this is from a 2017 survey, say 71% of people wish to die at home surrounded by loved ones. How can you tell? She's in her own home. You can see her quilt. You can see her daughter or her friend sitting on the bed with her. She's not in some hospital twin bed. She's got her artwork. She's got her family. She's not connected to machines. She looks happy and comfortable and peaceful and in her own home. And that's what most of us say we would like at the end of our life. And most people say they would choose improved quality of life over interventions that could prolong life while reducing its quality. The reality is that bottom slide. I'm sure that's not an unfamiliar slide or idea for most of us in this room. 35% of Americans die in acute care hospitals, and another 25% or 26% die in nursing homes as of some 2023 statistics. That's a combined 61% of people not having the death in that top picture. It looks more like the bottom picture. Deb's Law, which is how we usually refer to this bill now. Deb Robertson is a passionate advocate for this. Her story is very public. You can Google Deb's Law. You can find videos out there about Deb. She has a very rare and painful form of cancer. She has exhausted her treatment options, the standard treatments. She's been in some experimental treatments. I had the good fortune of getting to meet her a few weeks ago when we were celebrating this law, and she came to join with us and celebrate. And she's hanging in there, but she very much fears a painful end. And if that is to be the case at some point, she very much wants to be able to use medical aid in dying to bring about a peaceful end. The full name of the bill, Deb's Law, is the Illinois End-of-Life Options for Terminally Ill Patients Act. You can see that's a mouthful, and it's much easier to simply call it Deb's Law. But each of those words is really important because it's about expanding care, all kinds of end-of-life care that you see on this slide. And it's also about adding that last option of medical aid in dying. So I want to take a few minutes to make sure that we explain all the options that are available at the end of one's life. The first, I think, is pretty obvious, and that is pursuing treatment. We all know people for any number of diseases who have pursued all sorts of treatment options, and we hope that everybody is able to pursue the treatments that they wish that will cure them, extend their life, hopefully with good quality of life. However, people often don't realize that they can decline or discontinue treatment. Treatments for health conditions or to prolong life, such as the use of a ventilator, a feeding tube, IV hydration, antibiotics, CPR, can be refused or stopped at any time. Some treatments can be helpful, most treatments can be helpful, but it can also prolong the dying process and increase suffering without improving the quality of life. Pain and symptom management are used to ease comfort. Anyone has the right to refuse medical treatments. And it's important to note that if you're in a care facility, you may need to work closely with staff to ensure that care facility will honor your wishes. Palliative care is, of course, another option. It involves pain and symptom management through the use of medications and other therapies, such as massage therapy, acupuncture, even aromatherapy. Symptoms might be disease-related, such as pain, shortness of breath, or sleepiness, or they might be side effects from the treatment that you're undergoing, something like nausea from chemotherapy. Palliative pain and symptom management can be used at any time, with or without a terminal prognosis. You have the right to request as much pain medication as you need to stay comfortable, and palliative care is available in medical or assisted living settings and also in your own home. Hospice care focuses on quality rather than length of life, with the goal of providing comfort. It's a holistic approach that combines medical care, auxiliary therapy, and mental health support. The patient's loved ones may or may not be involved in this process by participating in counseling, family support services, and end-of-life planning. I'll add my little extra caveat here that says you should probably be thinking about end-of-life planning well before you're enrolled in hospice. Hospice nurses, though, or hospice teams, usually involve professionals including doctors, nurses, home health aides, social workers, chaplains, and others. To be clear, to qualify for hospice, you must have a prognosis of 6 months or less to live. Typically, curative and life-extending treatments are not available once an individual enters hospice care. And hospice care usually takes place in the home, often with help from family members or other loved ones. That can be supplemented by in-home care professionals, but in Illinois, all of that comes at the personal expense. It's not covered, that 24-hour care is not covered through hospice. The next option on here is something called VSED. Is that something people have heard of? Anyone in the room? A couple. Okay, good. That's still an option that's available, again, to anyone with a terminal prognosis. It stands for voluntarily stopping eating and drinking. A person who chooses to stop eating and drinking is choosing to forgo all forms of nutrition and hydration in order to control how and when they die. Every experience of VSED is different, and because VSED is a natural process, the symptoms and timeline can vary from person to person. For some, it can feel like a gradual, peaceful transition. For others, it may be more physically and emotionally challenging. Age, overall health, medications, illnesses, body type, fluid retention, and even a person's readiness to let go can all influence how the process unfolds. If someone chooses VSED, they should plan carefully to be sure they receive adequate symptom management, comfort care, and emotional support. Hospice services, end-of-life doulas, and caregivers can help during that process. And I can add a personal caveat to this. I was my neighbor's healthcare power of attorney about 3 years ago, and she chose me as her healthcare power of attorney because she was afraid that her family members would want to connect her to every machine and never let her go. After something catastrophic landed her in the hospital, she took a fall and broke every rib. That's when they discovered the cancer that she knew was there and had been ignoring. She didn't want any additional treatment. She'd gone through that several years before. She and I had had all these conversations, and I was able to work with her nephew, who was her financial power of attorney. We were able to bring her home to provide the hospice care that she needed, the comfort care, and through their financial help, provide her with round-the-clock nursing CNA care. And I was right downstairs, so I was up and back a few times a day checking on her. But I kid you not, when we got her out of the hospital, got that hospital bed set up in her living room, put her own pillowcases on the pillow there, the very first thing she said to me, I don't think she said hello, when they wheeled her in the room, she said, "You know, I just want to die, right?" I said, yes, we've had that conversation. I get it. We're going to try to make this as comfortable as possible. And through all those comfort care measures, eventually she did stop eating and drinking, and she lasted about 10 days in her own home, looking out over the pond that she loved in our condo building in Northbrook. So there are lots and lots of options before we get to this last one, which is medical aid in dying. So I want to make clear that when we talk about the name of this bill, it isn't just about using medical aid in dying. It's about making sure patients fully understand when they get that 6 months or less prognosis that all of these things are options for them. And in this world, we don't always get that full an explanation from doctors, social workers, nurses that are treating us or our loved ones. And to say more about medical aid in dying, and I'm going to skip through this part. So this is a note to think about who could speak for you if you are unable to speak for yourself. This is standard compassion and choices stuff that we find very important, that you should have a healthcare power of attorney or a proxy that you choose, and you give it a great deal of thought. My neighbor gave it a lot of thought when she decided not to have her nephew, because she had no kids. She kept him on financially, but she was afraid that he would have kept her in that hospital and forced her to do treatments that she didn't want to do. So never assume that a person will follow your wishes. Make sure you have lots of conversations with your healthcare proxy and that they understand whatever your wishes are. If you're one of the people in this room who wants everything and the kitchen sink thrown at you at the very end, that's your choice, and you should make sure your healthcare proxy knows those wishes and you get that. And if you're someone like me who thinks less is more, because I've seen a lot as a geriatric care manager, and I've learned a whole lot in the last 3 years with my own personal health challenges, I know that my wishes don't follow that everything and the kitchen sink model. You can choose, by the way, anyone to be your healthcare power of attorney. If you're married, it could be your spouse. It doesn't have to be your spouse. I actually hold power of attorney for a couple of longtime family friends, again, for the same reason. She's concerned that her husband would be too sentimental. Their son is their primary power of attorney, but if for some reason he's unavailable and she's incapacitated, she did not trust her husband to make the tough decisions. It's not something I look forward to doing. I've known them my whole life. They're in their 90s. But I'm honored that she asked me to do that. I want to note that in your advance directive, you can also specify who you would not want to be a healthcare proxy, because we probably all have those. I'm not going to get into the family dynamics issue, but these can be really thorny issues in families. If you have multiple children in a family, multiple siblings, that's why it's best to have one person as the primary and then backups if those people are not available. And by the way, I just had my own personal wake-up call from my estate planning attorney. I'm in the process of renewing my paperwork. She noticed that all 3 of my healthcare and financial powers of attorney were in my same 60-something age range. And she very politely said, maybe you should think about adding a 4th person of a different generation. I got the message, and my 36-year-old attorney cousin agreed to step up and, as he said, warm the bench in 4th place. So, one thing to note on this, it wasn't in these notes, but I think it's important for you to know that one thing your healthcare power of attorney cannot do for you is choose medical aid in dying. You have to be mentally capable. You have to make the request. You have to be able to self-ingest the medication. We'll get there in just a minute, but I want to make that 100% clear as we're talking about healthcare powers of attorney, that is the one power your healthcare power of attorney will not have, no matter who they are. So just a few more things on advanced directives in general. I really like the picture that the Compassion and Choice has put in here, because they're not sitting in a hospital, right? They're out somewhere. They're living their life. Hopefully, they're living their life happily wherever they are. This kind of looks Florida-ish to me, maybe. I'm not sure. But they've already had these conversations when there isn't a crisis. Whether or not they have a living will, some attorneys favor them, some do not. But definitely that healthcare power of attorney who will speak for you. There's other addendums that can further clarify your wishes. I've had to do this with my sister to really spell out the do's and don'ts and in really granular detail sometimes. And we have some wonderful booklets. I have just a handful of the old versions of this because it has that wrong map without Illinois and New York on it. But it does have information about how you would do this and the kinds of things you would put in your healthcare power of attorney. And again, even though we're here and we're talking about this at North Shore Senior Center, this is really something that's important for anyone 18 and over. This is an audience, I think, that probably remembers when there were young people like Terry Schiavo, who was a young married woman who was in a coma. One of the people that most gets associated with medical aid in dying was a young woman, I'm pretty sure it's Brandy Maynard. She was, I think, also in her 20s with a very aggressive, non-treatable glioblastoma, and she had to move to Oregon at that time because the state she lived in when she had that brain tumor did not permit the medical aid in dying. So everyone 18 and over should be thinking these things. And we hope it's something you won't use for decades, but to think about what your wishes are is really significant. So on to the heart of the matter. What is medical aid in dying? Medical aid in dying allows terminally ill adults to request and receive a prescription for medication that they may choose to take to bring about a peaceful death. To qualify, one must be mentally capable, able to self-ingest the medication, and have a prognosis of 6 months or less to live. Compassion and Choice's goal is to make medical aid in dying and make it open, accessible in all states, and a standard of care for end-of-life options. Just like it was on that other slide, just another bullet point with all the options you already have. The core guidelines, in addition to the 4 key eligibility requirements, there are 4, and they vary slightly by state. However, the practice standard of care includes 2 doctors, and in some states, a doctor and another healthcare provider. Some states allow PAs. Illinois does not. Both the primary physician and the consultant need to be physicians. They need another provider that confirms that terminal illness. They must have that prognosis of 6 months to live. They must be mentally capable of making their own healthcare decisions, and they're acting voluntarily and without coercion. Physicians are experts at determining their patients' mental capabilities. How many physicians do we have in the room? A few. Okay, good. I knew I'd have a few. So doctors are specially trained and required on a daily basis to assess whether patients have the mental capacity to make informed healthcare decisions. And that includes life and death decisions. If either the primary or the consulting physician is concerned about a patient's mental capacity, evaluation by a mental health specialist is required in Illinois before a prescription can be written. The thing that I found most intriguing about that statement was at one of the hearings I attended, I think it was one of the hearings in Springfield, a palliative care physician in Vermont was asked this question by one of the legislators. Well, what happens if there's a question about someone's mental capacity? And she said she knew her patients. They were patients she'd often been working with for palliative care for several months. And if she believed they no longer lacked decisional capacity, the process simply stopped. She didn't refer them to a consulting physician. That was noted in their records that the process ended. So if they tried to see a different doctor and skirt around the system, the first thing that doctor would ethically need to do would be to look at their medical records. And then they would discover, yes, they had this prognosis, but the physician who knew them best had said they lacked the mental capacity. And again, the process would stop. But if either doctor, maybe they don't know them that well, if they have a question, that's where that independent mental health evaluation would kick in. There's additional guidelines that vary by state that require written and verbal requests, different amounts of waiting periods, witnesses, and reporting. I want to be really clear about what medical aid in dying is not. If you saw the news when our bill passed, when New York's bill passed, some of these things come up by folks that are not so much in favor of this practice. And my answer to that normally is then don't do it. If you're not in favor of it for you, you don't have to. But I would prefer to have that option for myself. So what it is not is a substitute for the best possible end-of-life care. That whole range that we talked about, whether it's hospice and palliative care, different types of other types of comfort care, other types of therapy. If someone wants to choose VSED and not be as active in this process, it's not a failure of providers or their care. And I think this is a really difficult one for physicians and other healthcare providers. That's why there are so few geriatricians in this country. I was at an American Society on Aging Chicago roundtable workshop recently, and the number that I learned probably 20 or 30 years ago was that only about 5% of U.S. medical schools required one course in geriatric medicine. They all require one course in pediatric medicine. But that number, since I first learned, it was about 5%, probably when I first started doing these conferences and meetings in the early to mid 90s. Now in 2026, that number has eked up to a whopping 10%. And that's something that we need to fix, I think. And I think it's important to mention that we need providers that are used to working with an older adult population, because there's only one end for all of us, whenever that is, and that makes geriatric medicine practice a little less cheery, probably, than pediatric medicine practice. Medical aid in dying is not a substitute for palliative or hospice care. We absolutely want folks to be in hospice and palliative care. And if that's their choice through the end of their life, that is a perfectly reasonable choice. And as a former hospice volunteer, I can tell you that people often get that referral very, very, very late in the process. That for those folks that want that everything in the kitchen sink approach, that's what a lot of folks are getting, which is why you often hear people who have a difficult cancer struggle and they're in hospice for 2 or 3 days. And it's not the hospice that has ended their life. It's the fact that they got referred very late. I also knew many folks. I did a lot of data work at Journey Care. There were folks that we had in hospice for 6 months, 9 months, sometimes over a year. And hospice can actually improve that quality of life. It's amazing. And just as an aside, if you haven't read Driving Miss Norma, it's one of my favorite memoirs about a family where I think she's 98 or 99, Norma. She gets a stage 4 ovarian cancer diagnosis and decides to forgo treatment and spend the next year driving around in an RV with her son and daughter-in-law and their giant poodle. It's a beautiful story. She ends up in hospice care at the very end, but she has a fantastic year that didn't involve surgery and chemo and radiation. And I first got to meet her, metaphorically, on the Today Show, because as word spread as they were tooling around the country in their RV, people welcomed them to different cities. And it's a beautiful book. Medical aid in dying is not a substitute suicide. These are people who desperately want to live. If there's another experimental treatment they could do, these are people who want to do it. But the people who have made this choice are people who do not have that ability to cure the disease that they have. It's not euthanasia. Euthanasia is what we do with our pets. We're making that choice. The vet makes that action. This is completely different. This is not euthanasia. You have to make the decision. You have to self-ingest. This is your or an individual's choice. Medical aid in dying, especially in Illinois and in all of our states in the US, is not the same practice as other countries. If you've heard things about what happens in Switzerland or Canada or the Netherlands, it's not the same. It is not the answer to all end-of-life suffering. For many, many people, hospice and palliative care can adequately relieve their pain and suffering at the end of their lives. This is our new map, which will eventually be in our print material. It's easier to get it on a slide in the PowerPoint. It shows you the colors. The light blue shows you where medical aid in dying is currently authorized. So this is hot off the presses with Illinois and New York colored in. You can also see, and I find this really interesting, you can see it cuts across different areas of the country, different views of different people in different parts of the country, that there's active legislation. If my 7th grade social studies is correct, that looks like Nevada, New Mexico, Florida, Iowa, Minnesota. Minnesota is really heating up right now. Indiana, Kentucky, is that Tennessee, Pennsylvania? We've got the other states there, Massachusetts, Rhode Island, Connecticut, Maryland. So these are all states where there is some sort of activity on the ground, legislation that's been proposed, legislation that's somewhere in the pipeline with the hope of it being passed. Because that's the important part. I had this conversation with someone recently about why does it have to be legal? What's the important part about that? Well, if it's not legal and a physician were to write that prescription, That would be murder, right? If it's not legal. So we need the legal protection. We need everybody to be able to practice this in the correct way, within the framework of the law. And again, no one has to make this choice. This is just an option. That's why I really like the name of our bill as the Illinois End of Life Options Act. Still easier as Deb's Law. So this is probably an important slide as we're nearing the end here. The eligibility requirements for Illinois. You have to be an adult, which means you have to be 18 or over. Nobody under 18 can give their consent legally, so children are automatically left out of the picture. You have to be terminally ill. That means having a prognosis of 6 months or less to live. You have to be mentally capable of making informed decisions. So anybody with an advanced cognitive issue would automatically not be able to make this particular choice. They have to be able to self-ingest the medication. They must be a resident of Illinois. There's a whole long list in the bill, by the way, of different ways to prove that residency. And all of this has to be confirmed by 2 physicians. And to be clear, because this was something that came up a lot as we were advocating for the bill, a person is not eligible for aid in dying simply due to age or disability alone. And I think that bears repeating, that simply based on your age and especially a disability, that was a real key issue in this. That does not, if you're disabled and you have a prognosis of 6 months or less, you can apply or ask your doctor about medical aid in dying based on that prognosis of 6 months or less. Simply having some sort of a permanent disability does not qualify. I want to take a minute to talk about the members of the team, because at the end of life, care at the end of life must address the physical, emotional, and spiritual needs of patients, their family members, and loved ones. It really needs to be interdisciplinary, and this collaborative approach is no different from medical aid in dying. This is the hope that we have, all these different team members. While can be a tendency to focus on who's writing that prescription, we know in practice that every member of the team plays a very important role and that collaboration is the key. Often social workers are the first to get questions about medical aid in dying. Social workers are often nurses. We've had a lot of nurses come talk to us because they're the ones that are, if somebody's in the hospital, if they've had a complication from a treatment and they've just gotten that diagnosis, that prognosis of 6 months or less, they're spending more time probably with the social worker and the nurses than that quick doctor in and out visit in the hospital room. I'm sure we've all had those fast visits where you hope there's somebody in the room taking good notes so you know what they just told you. So this whole team of folks, we have the patient in the middle, truly patient-centered care, with the attending provider and that consulting provider, which again in Illinois, both need to be physicians. Hopefully your family and loved ones, again, if that relationship is good, you want to have those folks that are of comfort to the patient, right? And that sometimes is a little thorny with family members that might not see that relationship in the same way. There might be mental health professionals, hospice and palliative care. End-of-life doulas can be really important in this. That's a growing practice. I think most of us think of doulas as there for childbirth, but it's the same concept from the beginning to the end. Somebody who can be there to provide comfort, to help with the family, to help organize things, someone to talk with. I work with a fantastic death doula who is our Oak Park team leader. She has to just be the most caring, lovely, gentle person I've ever met. And I think most people who choose to go into, I would assume, doula work at either end of the spectrum have to have that caring in their heart to do that work. Obviously, nurses, social workers, and then ultimately that pharmacist is part of this. So each of these professionals and more can be part of the process, whether through documentation or presence, and depending on the person's individual situation and needs. Remember that in Illinois, again, those attending providers and consulting providers must both be physicians. In terms of that prescription, and this is where I'm going to stick to my script really closely because I'm not a doctor. Medical aid in dying medications, there is no required or standard prescription. The route of self-administration is considered. That concoction of medications is a mixture of medications that relieve nausea and anxiety, slow breathing, and ultimately stop the heart. They're prepared only by a compound pharmacy. It's not something you're going to get at Walgreens or CVS. And it's dispensed as a powder, and it's then mixed with 2 to 4 ounces of fluid at the time of self-administration. So that means that in terms of that physical ability to self-ingest, the person still needs to have the swallowing ability and dexterity to hold that cup and swallow this. Or if they have a feeding tube, they have to have the physical dexterity in their hands to push the plunger and do that. And that's all I'm going to stray from this, that there's not one single, it's not a pill that you swallow. Different doctors might have different combinations of these medications that they will prescribe, and they will be made by a compound pharmacy. And probably the most important slide I have, which is a reminder that it's the illness that's ending the person's life. These are people without whatever their underlying disease is, would very much want to live. And this is where I wanted to take a couple of the stats that I know. First, to say we prefer the term medical aid in dying to physician assist in dying, because the latter implies that the doctor administers the medication, as is the case with euthanasia. Compassionate Choices does not support euthanasia for people, which is illegal nationwide because the patient doesn't administer the medication themselves. So just to give some context here, this may be in our next round, we might have a slide on this next time. As of December 19th, 2025, so the most recent data that Compassionate Choices has from the states where this is legal, shows us that since this took effect in Oregon and these other states, a little more than 20,000 prescriptions have ever been written, and 12,425 people has actually taken them. That means about a third of the people request the prescription, leave it sitting over there, in case the day comes where they think they might need it, but that third of them take peace and comfort just from knowing it's sitting over there. Those other 61% did indeed use that medication. Put that in context, we're a nation of about 360 million people. This is not something that is happening willy-nilly all over the place. About 89% of those folks who have received this prescription are already enrolled in hospice and palliative care. So they've made that decision that the hospice and palliative care is just not sufficient for them, and they're making that choice to choose this additional option for medical aid in dying. In case you're wondering, the top 3 reasons that people make this choice, the 3 diseases at the top of the list, are cancer, heart disease, and neurologic disorders. And I'm guessing for the physicians in the room, and if we have nurses or other healthcare professionals, if you've seen people at the very end with advanced heart disease, with an advanced cancer that's beyond, that there's no additional treatment that's available, or neurologic disorders, things like ALS, they're very, very difficult at the end of life. Medical aid in dying is all about patient autonomy and the person having agency over their body. The patient is in charge, and they may request the medication, they take it, and they can change their mind at any time. It honors their autonomy. It provides opportunity to end needless suffering. It relieves fear and anxiety, and it leads to improvements in overall end-of-life care. That's because if we're really talking about all these other options, because this is another option, they still have to explain all that other stuff. So that means more people might be enrolling in hospice or palliative care that they choose not to do medical aid in dying, but it's because that is an option that they hear about the full range. So thank you for being here today in the room, on the Zoom. If you have questions, Chloe King is our senior campaign advisor. That's her email. It's really easy. cking@compassionatechoices.org. She can answer questions that I might not be able to, but we've got about 18 minutes or so, it looks like, to answer questions. And I know you have a way to do that.
Thank you, Maureen. Let's give her a big hand.
Thank you.
Arnie will take questions from our audience.
I'm going to give Jerry Frank, who's our geriatrician,
Okay.
opportunity for the first question.
Oh, well, I have a number of questions, but one question I have is, what about family? You have a patient that wants this, but you have family members that don't. How do you deal with that?
If the patient is mentally capable, just like any other decision, if somebody is able to make that decision, it rests with them. That's where having that hospice team, remember I said 89% of people who make this choice are already in hospice. So hospice social workers can help negotiate with the family, because that can be very thorny. There was just a terrific article, I'm trying to remember what publication, it was a 3-part series, maybe USA Today, that followed a woman in California through 3 parts. And the first part was her having that conversation with her family. She'd reached the end of her treatments. And then there was the talking and the negotiating about it. And then ultimately they chose to go to I want to say it was a family vacation home. And she wanted to be out in nature. And they did come around. But she at least had the time to have that conversation with them. But it's really the individual's choice as long as they're mentally competent to make that decision.
How does it affect a person's life insurance?
Oh, it doesn't. That's in the law, actually. That because it's the disease, it's the illness that causes the death. That's actually right there in the bill, that you're still going to be, your death certificate will say you died of cancer or heart disease, because it's not suicide, if that was the underlying question. So if you're concerned, you can read the whole bill. It's about 42 pages. It's SB 1950.
Question, does insurance pay for the cost related to this, including Medicare?
Medicare does, and it pays obviously for the hospice and palliative care costs. Medicare does pay for the medication. What doesn't is Medicaid does not pay for the actual medication, which I think is about $400 to $500. And when I've been asked that question before, I know that in states where it's currently legal, there is something parallel to what in Chicago is called the Chicago Abortion Fund that pays for women in states where they're not permitted to have abortions to travel to Illinois to have that abortion. And there's private funds that are raised for that. Our hope is that at some point, there will be a nonprofit in Illinois that will help with that $400 or $500 cost. But their actual medical care is certainly covered by that.
I have a question about how doctors themselves feel about prescribing such medications. Is there pushback from doctors and others authorized to do that?
From what I've heard through Compassionate Choices, the longer a state has the medical aid in dying that's legal, the more comfortable the physicians seem to be. Oddly, one of my childhood friends was one of the first authors. He's an oncologist in Oregon, and he helped with that first law and is still a practicing oncologist and is often the consulting physician for cancer patients in Oregon. So you see more utilization, but I can tell you that in some cases, there's no reason not to say it. Now that I saw my cardiologist for the first time since the governor signed the law, and she knows I've been working on this for 3.5 years. We've had conversations about, that was a good thing. How are you doing? You made it to Springfield to do some advocacy work. And when I said to her just last week, how would you feel if I ever were in that end stage heart failure? Her answer was a hard no. But what's also in the law is if a physician is not comfortable, and they're not obligated, by the way, no physician is obligated, they do need to refer you to someone who would write the prescription. And that was her follow-up, which was, I would refer you to a palliative care physician. So I think it's going to be an evolving thing, and you really are the very first group to hear any of this in this sort of a public forum. That's a great question.
The thing that concerns me is something like dementia or Alzheimer's, where you wouldn't be competent to decide, but there's like zero quality of life. What was discussed, or what do you know about options for somebody in that situation?
Medical aid in dying would be off the table if if their physician has said they are no longer capable of making their own healthcare decisions, and their healthcare power of attorney is making their decisions. So if, say, God forbid, that person with dementia were in a car accident and they ended up on a ventilator, their healthcare power of attorney could make that choice, but their healthcare power of attorney could not at any point once they have that. And again, that's a decisional capacity choice. There's people in early stage dementia that are still driving, that are still doing things. There are different types of dementias. So it isn't an automatic, but it's about that. That's where in Illinois, you need those two consulting physicians. And if either of them has a concern, that's where somebody else, a mental health professional, would assess that decisional capacity. Yeah, if you could, by the way, just have that discussion in advance. That's why while you have all your faculties and your wits about you, you could say to your spouse, perhaps who's your healthcare power of attorney, if I ever end up in advanced dementia and I get a cancer diagnosis, I don't want any treatment. So that you can, but you'd have to do that while you have the decisional capacity. And ultimately, it's that healthcare proxy's decision, because you're not going to be able to make it.
Maureen, your colleague, Chloe Izzy King,
Yes.
has this comment that I'd like to read.
Thank you.
Sure. There are some very limited instances where someone with mild dementia who also had a terminal illness may be eligible, but folks who are in late stage dementia would not be eligible.
Thanks, Chloe.
I am a retired nurse, and I was involved in hospice, and there was a woman that came into
Hold the microphone parallel to the floor.
Okay. So her family was asking me all kinds of questions, and one of the questions was, what comes after hospice? And I really didn't know how to answer, but I said, you need to discuss that with your physician.
Well, the answer, and I did hear it from someone out here in the audience, what comes after hospice is death. It's just a matter of when and how. And until September 12th, 2026, that's still the only answer. But after September 12th, 2026, when Deb's Law is fully effective and all that paperwork and tracking and those systems are all in place so that we can get that data and know what's happening, and we know which pharmacies are going to be compounding the medication, we know which physicians are willing to write that prescription, then there is another option. But right now, this is just about education for us to spread the word and let people know it's coming as a consideration.
Helping another family whose family member was dying, and she did not want to go against her family. But I said to them, she is waiting for permission from you to die. And so once she got that permission, she was able to die.
I've seen that so many times. I understand, and that is often what people are waiting for. But family, we could have a whole conversation here about the complications of family, right? Yeah.
You mentioned the comfort that a person has knowing the script is over there on the table. What's the expiration date of the medication?
Ooh, that's a good question. I'm going to guess it's got to be 6 months or less because that's our but I really don't know. Chloe, if you know the answer to that, and you want to put it in the chat, feel free. But because again, we're only talking about people with a prognosis of 6 months or less. There's always going to be those outliers if anybody's done hospice work, but usually it's way less than the average hospice stay is 2 or 3 days.
Chloe says there is no expiration date on the medication. In the vast majority of cases, patients are requesting within 1 to 2 months of death.
Thanks, Chloe. I love having her on Zoom.
We have 33 people on Zoom.
Wonderful.
And 79 here.
Wow.
One of them, who is Wilma Tunick, she says, my daughter Linda Downs went to school with the speaker. And she's watching from Florida.
Okay.
She also has a question. Let me get to it. How many compound pharmacies are there and how do you find them?
Well, that is something we're working on right now. So the answer, we hope by September 12th will be at least 1 or 2 in Illinois, because this might be, again, this is not something you're going to get at Walgreens. So it's probably something that you're going to drive to pick up, or they're going to FedEx with all those special signatures to you, like overnight it, the way you would something really precious and important. So we don't have that because, again, nobody can do this next week. And that's always really painful when we do these talks. If you have people in your life who are actively suffering, there's not much we can do until September 12th. Where's our next question? There we go.
Hi, mine is not really a question. I'm sorry. It was a question, but now I've been an advocate for this bill for years, and I wish I knew about compassion and choices because I would have volunteered for.
Still can. We have room to get you as a volunteer. Come see me after.
I have a lot of friends that live in Washington and Oregon who also help with medical aid and dying. And so I've learned a lot from them. And I also have a sister with dementia and been in the nursing home for 5 years, who I visit every night. And I'm seeing long-term, anyway, I'm an advocate for this, okay?
Wonderful.
But I've investigated because one person that we knew went to Switzerland for dementia. Because in Switzerland and Denmark, you can have, if you dementia, you can have medical aid in dying. So I asked my lawyer, because I redid my power. I asked my lawyer, and the lawyer said, whoever inherits your property or whatever could not inherit it if they take you to Switzerland. So check it out. Or
just stay focused on Illinois, because it's that's part of the reason we work so hard to get this to be legal in Illinois with the protections and not helping, unfortunately, folks with advanced dementia.
Well,
but to have the wherewithal to make those trips, most folks, again, there's 360 million of us in the United States, are not going to have the wherewithal.
But even with a coma, et cetera, I found out personally from a 38-year-old who commits suicide. Because he had 6 months to live and he couldn't get to another, you have to have 6 months in the other state too. I'm just, so he couldn't, so we looked all over for him and he hung himself.
Well, thank you.
You said that Endeavor will pay for these compounds? Or are we gonna have to pay for them ourselves or?
Well, if you're 65 or over, Medicare does pay for them currently. Medicaid for people who are younger does not. Your regular insurance, it's going to be, the goal is that it's a regular standard of care. It's not going to be an outlier. It's not an experimental thing. It's just something that's part of someday when every medical school requires one course in geriatric medicine. part of this is going to be this end of life care that's going to go through hospice and palliative care and VSED and medical aid in dying. But clearly, we're 90% away from that still. Edie,
I don't have a question. Can you hear me? Yep.
closer.
Okay. I don't have a question, but a comment. I have been in Springfield. I support this bill and have also been in I'm 63, have also been in Springfield about 3 times in the past 6 months to a year. And I'm also a physical therapist, so I have a little bit of experience, but I have never heard you speak before. And I have to say, you are absolutely outstanding.
She's not a plant. I do know, Edie.
It's just absolutely
Okay.
amazing. So thank you very much for, I've learned a ton. Thank you.
Well, thank you for coming and supporting me. I appreciate it. I see one more down here.
Did you mean that with dementia, a person could let their power of attorney for healthcare know that toward the end, when you didn't have any more life to be enjoyed, that your power of attorney could undertake this?
Not medical aid in dying, but they could do anything else if you've had that conversation with them. We have I can give you a little booklet that talks about that process, that we have a dementia addendum. So while you do not have dementia and have all your faculties, you can write down your wishes and say, under these circumstances, would I want antibiotics if I had pneumonia? Would I want chemo or radiation if I had cancer? Would I want CPR if my heart stopped? And you can direct your power of attorney to say, if I have dementia and I no longer recognize my children and I no longer know who the president is and what day of the week it is, and I'm no longer speaking, you can lay out your parameters for your healthcare proxy, and then it's up to them to enact it. But you can do that while you don't have that dementia diagnosis. But you can't do medical aid in dying.
You can't do that.
That you cannot do.
You can't have them do it.
Nope. Because you have to be mentally capable. When you pick up that glass, you have to have all of your faculties about you.
Questions? From the internet?
We have one more.
Okay. And then I think we're at time.
Thank you, Maureen. To split hairs here, because my sister's husband has a diagnosis of Alzheimer's. He's capable, he's cognitive presently, but he would not qualify, even if they have a conversation now.
Well, if he's cognizant, if he's capable now,
Okay,
if he has decisional capacity now, and God forbid, got a terminal diagnosis, but it takes a while to get a terminal diagnosis. Usually you have to go through some steps of treatment before they say, there's nothing left we could do for you.
gotcha. So he could have a conversation with my sister POA, say if I ever get heart disease, cancer, or ALS, God forbid, then he qualifies and they've had the conversation.
But he still can't have medical aid in dying. He can refuse all the treatment.
That's what I wanted to
Yeah,
hear.
the medical aid in dying is only something you personally can choose for yourself. And once your decisional capacity has left you, that choice is no longer on the table for you.
That's what I wanted to hear.
Yeah.
So it's null and void. Thank
It's null and void. It just ends. And that's a fear that people have had over and over. That's why it's a common, I was interesting. I was thrilled to hear what your question would be today, because I've never been able to talk about this as Deb's Law. So thank you so much. I have a few handouts I'm more than happy to distribute. The only difference, I believe, main difference will be that map, will be the map you saw on the slides, because these are from last year.
Has another comment. She wants to add, he has to request medical aid in dying. Why, while he is both mentally competent and has a prognosis of 6 months or less to live at the same time. So no, my understanding would be you cannot put this in and say, hey, if this ever happens to me, I want you to do this to me.
Right.
You have to be cognizant at the time
At the time,
to be able to lift it, swallow it, and say, this is what I want.
right.